Hi, Lincoln.
Hi, how are you?
I'm good. We're down here in
So
Jamaica this week.
I've just got us signed on, so we're going to wait for some of the other attendees to get on. You want to tell us a little bit about what you're doing in Jamaica right now?
Yeah. Hey, Caroline, come on up here. So, yeah, we've been down here in Jamaica. I've been working with
Hi.
Dr.
How
David
are
Brown.
you?
He's from Michigan, and we've been doing cataract surgery down here. And that's one of the things that our office does. One of our outreaches is we go different places around the world and do cataract surgery. So I've probably been to Jamaica the most. Caroline, I've got to know very well through the years. We've been to West Africa, Ivory Coast. We've been to Guatemala. We've been to Bolivia many times, been to Nicaragua several times, been to Haiti several times. But Jamaica is one of our second homes. We have great friends down
It is.
here. We've had a surgery center up, and we've had a good week.
You've been twice this month.
Okay, I've been twice this month. All right. Okay, it snowed a week ago. It's not snowing here in Jamaica, so it's been a pretty nice thing. And as you know, Lakin, we had set this all up to do this, and then I found out, oh, I'm scheduled to do surgery down in Jamaica. So Lakin worked very dutifully and got this all set up so that I can be here and she can be there in Ohio, and we both can be at the same place at the same time via Zoom, right? So
We made it work.
we made it work. So thanks, Caroline.
You're welcome back. Bye.
Bye. All right, Dr. Stahl, I'm just going to check. It looks like we've got about 42 people in attendance at the moment. So we can go ahead and get started if you'd like.
Yeah, that'd be great, Lincoln.
Okay. So we're just going to answer some questions that are pretty general questions about cataract surgery. We'll start there, and then we'll go into a little bit more specific questions a little bit later. So we're going to start with, what is a cataract?
If we all live long enough, we're all going to get a cataract. The natural lens inside our eye starts to turn yellow and cloudy, and eventually it gets dense enough that it becomes a cataract. And when that density gets bad enough and your vision gets poor enough, and you kind of know, then that's when we start considering cataract surgery. So if we're all fortunate enough to live long enough, we're all going to get cataracts at some point. It's just where your lens turns cloudy.
And how will patients specifically know when it is time for cataract surgery or to seek the evaluation?
Yeah, that's a really good question. And there's a couple things that you're probably going to notice. One, when you're driving into the morning sun or the evening sun, you might notice that. Second one that I've started noticing my patients notice, when you're turning left at night, especially in the rain, and you can't see where you're turning left into. Or if you're in a dark room with bright sunshine streaming in, you can't see your keyboard. Sometimes you just notice that your eyes are tired at work and you're just not seeing very sharply. All of those can be symptoms of cataracts. We do have a great online quiz for people too, so you can take that quiz. But the real way to know is to go and see your doctor, your eye doctor, and say, hey, what do my lenses look like? Do I have cataracts? And they'll be able to tell you. But most people start to notice those things. Glare at nighttime, trouble driving in dark conditions, trouble seeing at nighttime, morning sunshine, trouble seeing in a dark room when you have bright sunshine streaming into the room.
And what would be some of the benefits to having cataract surgery?
Yeah, it's kind of one of those, if it ain't broke, don't fix it sort of things. If you're not having problems with the cataracts, then you probably don't need cataract surgery. But it works the other way around too. If you're not seeing well and you're not comfortable, and like I'll joke with patients and I'll say, hey, having any trouble driving at night? And they say, nope, no problems at all. I go, how much do you drive at night? I go, oh, I never drive at night. I'm not comfortable. I can't see at night. Well, that's a problem when you quit doing things because you don't feel like you're doing very well. So we have, some criteria that we go by from an insurance standpoint, but the benefits of doing it are to get back your life, to be able to see, to be more active, to be able to do more things clearly again.
And what if the cataracts aren't ready? Can they still have surgery?
Yeah, that happens sometimes. Sometimes people come in and they'll say, well, is it ripe? And we don't use those terms anymore, but there are insurance industry standards. And if the standard is, oh gosh, you have to be so bad for it, you can have your cataract surgery, and it's not, well, then people can still do that surgery. And it's an elective procedure, fancy word for self-pay. You pay, the insurance company won't. And we have some great options nowadays that kind of trigger people to do that. In the old days, we had just regular implant lenses, but now we have some bifocal implants that we'll talk about here in a little bit, and the astigmatism correcting implants, that those maybe make you see better than you did even with your glasses or contacts. So some people just choose to go forward with it and self-pay.
Do our patients have to go to the hospital to have the surgery or be put all the way to sleep?
That's a real good question. That's something that makes people very anxious and nervous. Fortunately, we have our own surgery center that's in our building, in our office. You don't have to go to a hospital. This is still a real good time not to go to a hospital. The joke with doctors is, what happens when you go to a hospital? Then you get really sick when you show up at a hospital. So yeah, you don't have to go, and you don't have to be put to sleep. It is much safer with a local anesthetic. Now, yeah, you're still sedated, so you don't feel anxious. But a local sedation, you're breathing on your own, it's safer. You get to go home the same morning you come in, just much easier and safer all the way around.
And then in regards to the surgery itself, does the actual surgery hurt? Is there pain associated with it?
Yeah, the surgery doesn't hurt. We've got really good local anesthetics that we put on there. So in addition to give you a little bit of sedation, now you're still awake, you can still talk, you can still breathe, a little bit of local sedation, but we use topical anesthesia, so you don't really feel the surgery. Most people will see this bright light, and we say just look right at the light. But yeah, it's not painful surgery to have done, and it's not a terribly long surgery. You're only in the operating room probably about 12 minutes total.
And do the patients need to stay completely still, or how do they keep their eye open for surgery?
Yeah, most people are moving a little. You're still breathing and you may be talking to us. So you're moving a little bit, and that doesn't upset the surgery at all. We do use a lid speculum. There's a thing that helps keep your eye open so you don't have to worry about blinking, because people are a little apprehensive about that. Well, they hold my eye open. And the answer is you don't have to worry about it. We have a speculum that keeps your eye open so that you don't have to worry about doing that.
And now that we've talked a little bit about surgery itself, can you tell me some of the restrictions for after surgery that patients would be expected to stay at?
Yeah, the joke is this is not your grandmother's cataract surgery. Some of you will remember way back when, where your grandmother or grandfather maybe had to stay in the hospital for 3 days, and they weren't allowed to get up and go to the bathroom, and had all these restrictions. Most of our patients, they're going home that afternoon and taking care of themselves. They have a patch on for the first 2 hours. We take that off, get started with the drops, but you can bend over, you can cook for yourself, you can go out for walks. Now, I'd rather you didn't drive the day of your surgery because you're going to be sedated. And I'd rather you had a driver for the next morning so that we can tell how well you're seeing. But a lot of people are driving the next day, maybe not working, but they're able to go for walks and do most normal activities within a day. So you're not out of commission or off of work very long at all.
Okay, I'm going to hold right there for just a minute. The internet connection down there is super far from us, so we're just going to let it kind of keep up with us for a second. It's starting to freeze a little bit. Looks like it might be okay. Let's go ahead and talk about, so those are some of the restrictions that we're looking for patients to keep. It's really important for patients to know when is it that they can go back to work. And
Hey, Lakin, that cut off for just a second.
okay, give me just a second. I'm going to get that back on here for us.
Yeah, I guess when you do this from really far away, you're going to have that sometimes, right?
We're making it work. I'm doing the best. There we go. Is that good?
I see me. I don't see you yet. So do the split screen. Yeah, there we go.
Okay.
Yeah, we're back.
So we'll pick up where we left off.
Yeah.
And that question was, so it's really important for patients to know when it is that they can go back to working and driving again.
Yeah, pretty quick recovery. Again, I don't want you maybe driving the day of your surgery, but most people, after they see us the next morning, they can drive later that afternoon. Most people can go back to work within a day. Some people go play golf the next day. Now, there are some restrictions. I don't want you lifting over 40 pounds the first week. You'll be sleeping with an eye shield over your eye for the first couple of weeks. You'll be using some eye drops, maybe not working out excessively the first week. So there are some restrictions because you just had surgery, but the restrictions are fairly minor and certainly not to limit you. You're going to be able to get back to work very, very soon.
All right. And then are both eyes done the same day with this surgery?
No, normally we don't do both eyes at the same time for safety reasons. We'll usually do one eye, wait 3 weeks, and then come back and do the second eye. And that just turns out a little better. Sometimes after we do the first eye, we'll do some measurement. We'll look and we'll say, gosh, I think we get a little better results if we did this. So sometimes we wait to do the second eye for 3 weeks just so we can do some fine tuning for that second eye.
And so until we do the second eye, a lot of people would think that there's going to be an imbalance there with the other eye. So what is it that we typically advise patients to do with their vision for their contacts or their glasses for in between surgeries?
Yeah, that's an excellent question because there is an imbalance, especially if you have a really high prescription. So, when we're doing cataract surgery now, we're kind of eliminating those high prescriptions. So if you happen to have really thick, heavy glasses or a high prescription, we're going to be able to reduce that a lot. So when you have it done, you may not need your old glasses prescription and the old contacts won't work anymore. Now, if you're wearing contacts, a lot of times what you can do is go back to wearing a contact just in the other eye, just in one eye, let it heal a little bit, but you still need to come out of that contact for 4 days before your surgery. If you're wearing glasses, sometimes we can kick the lens out of one side and get that to work. But a lot of times if you have enough imbalance, the best option is just to go with the one eye and muddle through, get through. And everybody seems to manage it. Now, once we get that other eye done, everybody goes, wow, that's a whole lot better. But sometimes we just have to muddle through between the two eyes.
Okay. And in reference to the cataract itself, will it ever come back?
The cataract never comes back, which is fortunate. Now, most people will get a thin film. It grows over the back of the implant lens. And when you take your cataract out, you have to put an implant in. The implant takes the natural focusing power of the eye up in place of what became a cataract. That gets a cloud over it. And then that we clean off with a laser treatment. Very simple to do, 5-minute procedure, done in the office. Clean that off, get you seeing a little bit better. So the cataract never comes back. And it's called capsule haze. You'll get a thin film go over the back of the implant lens, cleaned off once in your life.
Okay. And in reference to the cataract surgery, does your medical insurance offer coverage for this type of procedure?
Yeah, normally your insurance covers this. Now, most of you might know, you have a deductible or you have a copay. And if you've been in the medical system a little bit and had other doctor's visits, you may know how that works. But subject to that, it usually is covered. Now, some people, as we talked about prior, they don't have a significant cataract. And if it's not ready for insurance, sometimes people can do the cataract surgery on a self-pay basis, an elective basis.
Okay. And then when we're talking about surgery and lenses, we've referenced upgraded lenses or advanced lifestyle lenses a few times during the webinar. Can you tell me a little bit about those specific lenses and maybe what they offer for better vision?
Yeah, in the last 20 years, the surgery that we have for cataract surgery has really improved a lot. And probably the biggest improvement in that is the lenses. In yesteryear, you put a lens in there and people still wore their glasses. And some people needed thicker, heavier glasses after cataract surgery, right? Nowadays, we're actually able to eliminate a lot of your refractive error. So if you're nearsighted or farsighted, or especially if you have a lot of astigmatism, we can put an implant lens in there. Well, one of the other things that happens as we get older is we lose the ability to see things up close. Has a fancy name called presbyopia. It is not farsightedness, it's a different thing, but you can't see up close anymore. And we actually have implants that correct for that, a kind of a bifocal implant. Now, it's not like the bifocal in your glasses. When you're wearing a bifocal in your glasses, you have to use it down here and you can only see down here and you're reaching on the top shelf and you can't see up there. Well, these bifocal implants are more like when we were younger. They improve your vision so you can see good for far away. Good for intermediate. That's that awkward distance a lot of us trouble with, like the dashboard in a car or a desktop computer. It's just past your bifocal, but not quite all the way out. And then fairly good reading up to medium-sized print. Now, if you're trying to thread a needle or ultra small print, probably still need a strong pair of reading glasses for that. But for medium-sized things, we can get you seeing pretty good without your glasses and contacts.
So with those advanced lifestyle lenses, we've referred to them as an upgraded lens, something that maybe your insurance wouldn't cover because it is a luxury type of item. Do we offer financing options for something like that?
Yeah, that's a really good question. So yeah, it's an upgrade. Your insurance doesn't cover it, but you're allowed to pay privately for it. And we have really good financing programs for that. So the most popular one is like a 2 years deferred interest, where the practice defers the interest for you. You still have to make regular payments as you go along, but you don't have to pay interest for up to 2 years. And that spreads the cost of that out over time. Obviously, we take credit cards and checks and even cash. Remember those green things that people used to use? We take cash still too, but a lot of people are choosing one of the deferred interest finance plans. And our goal is we want to make everything affordable for everything. If this is something they desire, if they want to start seeing better without their glasses or contacts, we want to put it within your budget so that you can afford to do it.
And the company that we use for that financing option is Care Credit. So I know a lot of patients already have Care Credit for their vet bills, or maybe they use it at the pharmacy for prescriptions, or they've used it for some type of dental. And they don't have to take out a new credit card. It's just something maybe they already have. Now, what would be the next step for the patients if they're interested in being seen for an exam?
The next step is to schedule an eye exam, and that can be with your local optometrist, or if you want to come see us. Now, if you see us, that is billed to your health insurance because it's a medical exam, right? And then we're going to look at you, and then we usually just go pretty much common sense. We kind of ask you where you're having problems with your vision, how much problems are you having. We look to see if you have any other eye problems. We talk about some of these lens choices. You're going to be there because it's a fairly thorough eye exam, right? And then we look and say, hey, this is what we can do to help you see a little bit better. And amazingly enough, in an AARP study, they found that 2/3 of the patients, when they finally had their cataract surgery, they were surprised or shocked how much better their vision was after. They didn't even realize how poor their vision had gotten until after they had it restored and went, oh my gosh, I've been going around and just not seeing very well.
So I have a kind of funny story that happened today. Denise, she's one of our patient educators. She visits all of our cataract rooms and talks to the patients and kind of walks them through the process a little bit before they sit with the scheduler. So Denise just recently had her surgery, and you did it. This morning, I heard her talking about her shirt that she came in, and she's so nice. She's so sweet. She's an angel walking earth. And she was just so funny because she was like, I could see that my shirt was magenta. I couldn't tell before that it was magenta, but I can see that it's magenta. I was like, oh, my shirt is magenta. So she can see colors and she can see things that she couldn't see before, but she had no idea how bad it actually was.
Yeah, blue colors like this blue top, a lot of people will find that some of their darker blues look like navy or black to them, and they'll get it done. They go, oh my gosh, blue colors are so much better, just like Denise experienced.
I've heard patients say that at one point they had painted their kitchen like a red color, and then after their cataract surgery, they couldn't believe that that was the color that they actually picked for their kitchen, because that is not the color that they thought they were getting.
Right.
So it definitely changes their vision. All right, so we're going to go into a couple more lengthy questions. These might be more specialized or more centralized around specific patients themselves. So I think we've already, did we already talk about
It froze there for a second. Lincoln, can you ask that? Oh, reconnect. It's doing surprisingly good.
Not doing bad. Let me.
There we go. Thank you all for being patient. We're 3,000 miles away.
All right. Good?
Good.
Okay. Did we talk about patients that are diabetic or that have diabetes? Did we talk
Oh,
about that yet?
and yeah, we should talk
Okay.
about that. You know, go ahead.
So a couple things oh, go ahead. I'm sorry.
Yeah, diabetes is problematic for people in their eyes. So if you have diabetes, there are three organ systems that can be affected by that. Your eyes, your kidneys, and peripheral nerves primarily. And, oh, broke up again. Hang on a second, folks. We just put it back together. There we go.
All right. Try number 2 or 3.
There you go. All right. So we're talking about diabetes. Okay. So yeah, if you have diabetes, there's some practical things you should be doing. First, you need to get your eyes checked every single year. Second, just to keep your eyes healthy, you want to be on a low carbohydrate diet, exercise regularly, and then work with your doctor to keep your blood sugars down. Now, even despite doing all of that, diabetic patients tend to get cataracts both at an earlier age and they tend to grow faster. So a lot of our diabetic patients are getting cataract surgery at a much younger age than other people.
Okay. And then a few other eye conditions that we might be thinking about looking at, things like macular degeneration or glaucoma, and how that can affect the eye and their surgery.
Yeah, a lot of us have heard those words, mac generation, which is an aging change that causes some loss of vision, and glaucoma, which is a pressure problem in the eye. And when you come in for your exam, we're going to look for those things. Now, for some people, maybe you already know you have pretty bad mac generation and you happen to have cataracts. So it's going to be a mixed thing. Let's say the cataract's 50% of the problem and the mac generation's 50% of the problem. Well, the mac generation may not be fixable. And so we'll take the cataract out and we'll know that you're not going to see perfect. So doctors have a fancy word for that. They call it a guarded prognosis, right? It means it's going to be better, but it's not going to be perfect. Now, still, at some point, you need to take the cataract out. And at some point, you need to take it out so you can see the back of the eye and make sure it stays healthy. But for some people, it's not going to be perfect vision afterwards.
Okay. And then let's talk about one. So we did get a few questions in prior to the seminar. The one question that I got that I thought we should talk about was Fuchs dystrophy and how that may affect surgery also.
Yeah, there's a genetic condition that causes your cornea to start to wear out faster than other parts. The cornea is the clear cover right on the front of your eye, right in front of the colored part of the eye. And those cells are supposed to pump the water out and keep your vision clear. Well, for some people, they stop pumping very well and they start aging faster than other parts. And for some people, it ages so fast, it starts pumping so poorly that they start to cloud over and they can't see. And to the point that some people need a corneal transplant, a new cornea. Now, that technology has improved tremendously in the last few years, where people are doing better and faster with corneal transplant surgery. Now, when we do cataract surgery, if you have this condition, and again, it's called Fuchs dystrophy, if you have it, there's nothing you can do about it. It's genetic. It's just something you're going to have. Well, sometimes you'll have more swelling with cataract surgery and a little longer recovery. Now, there are things we can do. We can put you on different drops and extra drops to decrease the amount of swelling that you have. So there are things that we can sometimes do if you have Fuchs dystrophy.
Okay. So those are pretty much all the questions that I have. We pretty much went over everything that was general and some more specialized questions. So I'm going to give the attendees a minute, see if they have a couple questions that they.
Might have broken up, Lakin. Might have to restart it one more time. Overall, pretty good. There we go. Hey, well, Lakin's resetting that. Another thought I was thinking about self-pay thing. We have a lot of patients come in thinking that they're going to get LASIK surgery done, right? And if you're in that between 50 and 60 years old, Sometimes we'll look and say, gosh, maybe LASIK surgery isn't the best option. Maybe something more like cataract surgery, which we call refractive lens exchange. So it's like a self-pay option. So if you've got fairly significant cataracts or early cataracts, sometimes we'll look at that and we'll say, LASIK doesn't really stop that because it's still clouding behind your cornea, right? So, and your prescription's going to start changing. So if you have a significant cataract or the beginnings of cataracts, we'll look at that and say, LASIK's not going to help you much. First of all, it doesn't help your near vision terribly much. And second, you're still going to have your eyes changing in behind that. So that's that self-pay option. People can do something called refractive lens exchange. We still use those bifocal implant lenses, and we can restore people's vision. And the nice thing of that is, if you have that now, you won't need cataract surgery later. And with those bifocal implants, we can get people seeing far away, and we can get their near vision back for them too. And we use those same financing options, the deferred interest financing options. And some employers have things called an HSA or an FSA. And if you know what those letters are, you probably have one, right? It's like a tax deferred savings account. And patients can use those as a medical expense for that. And that's a great way to pay for things in the medical field because you're using pre-tax dollars to pay for those. So that's another option, both for LASIK patients, cataract patients, and RLE patients. They can use an HSA or an FSA savings account to help pay for some of their medical expenses.
I'm really glad that you talked about how refractive lens exchange or even cataract surgery is sometimes a better option for patients than LASIK, because I know myself and my partner Maureen, we speak on the phone with LASIK patients a good majority of the day, and we have a lot of patients that call our line that are interested in LASIK surgery. And when we try to talk to them a little bit about that, sometimes it can sound like maybe we called them old, and cataracts don't come in patients that are old. So sometimes you see patients that have congenital cataracts, means they've had them since birth. And patients that have developed them just early on in life. So again, it doesn't necessarily mean that you're an older patient, just means that lens change happened. And some patients have traumatic cataracts too. So it doesn't mean that you're old, just means that there's a better option, and we want you to take a better advantage of the better option.
Yeah. And called vision for life. We have different procedures for different age groups, and we have something that works for everybody. And we're always going to want to choose what's going to work best for that person, right?
All right. Dr. Stahl, are you ready to look at some of the questions that have popped up for us?
Yeah, absolutely, Lakin.
All right. I'm going to scan through these really quick and see what we got. So I have Jim Hollander says, since Medicare does not cover the multifocus lenses, what is the cost to an upgraded lens?
Yeah, we have two categories of lenses. The Cadillac of them, or the Tesla of them all, is called a synergy lens. It's a bifocal lens. And I think that lens is $2,500 extra per eye that people pay for. And it's a non-covered service. And that is the lens that gets you seeing good for far away, good for intermediate, and good for up close. There's also another lens, which is called a toric or a plus lens. And that lens works really good for distance vision, really good for intermediate, but not as good for very fine print. So you might still need reading glasses. Now, there's, of course, regular implant lenses that cost nothing extra, no upgrade for it, but that's still going to leave in your glasses most of the time. So a pretty fair percentage of our patients, matter of fact, 2 out of 3 of our patients are choosing to pay this upgrade just for the freedom to be independent of their glasses and contacts. So we've got 2 good options.
And then when we're thinking just cost wise, I just ran the numbers very quickly, and on that puts, if they were to finance that, that puts that lens somewhere between $50 and maybe $105 a month, depending on the lens that you choose, if you were to take advantage also of the care credit option that we offer.
Yeah, and that's excellent. Thanks, Lakin.
You're welcome. I'm going to go back to the questions very quick. Eileen would like to know if you can have both eyes corrected at the same time. And I do think that we answered that one. That was very early in.
Yeah, but I'll go over that because it's a good question, Eileen. For some practical reasons, safety reasons, and result reasons, we don't like to do both eyes at the same time. Now, we do that for LASIK surgery, But for refractive lens exchange and cataract surgery, we do one eye, we measure it, see how close you got, and then sometimes we'll make some adjustments, some fine tuning, and we'll choose a different lens or choose a different power when we go to do the second eye. Now we try and get them close together, so you're not lopsided very long, about 3 weeks, but we try and do them about 2-3 weeks apart.
Okay. There was one that I really liked, and I love to hear the answer to this one. Jim, who asked the question earlier about the different types of lenses, would like to know what differentiates Stahl and Dr. Knowles, so Stahl Vision, from other providers.
You know, we're really fortunate at Dayton. We have lots of really good eye doctors. And I'll tell you, it's a very collegial town. All the eye doctors get along very well together. So I've got great buddies in town. Now, Dr. Knowles and I have been doing this a long time. I personally have been in practice 24 years and have done this probably 30,000 times. So I guess the advantage we have is that we've got a lot of experience. We've been doing it a lot. And then the other thing is kind of like a hobby or a pastime for me. We work on those formulas that picks which implant you need, right? And there's a lot of math, a lot of science, and helps to have 30,000 patients you've done before. We have really accurate nomograms. As a matter of fact, we compare our numbers to numbers that are published nationwide, and our numbers are just better. And we work really hard at it. That's something I kind of enjoy doing, right? So our goal isn't just get the cataract out. Our goal is to get you seeing better and maybe not your glasses and contacts. So our nomograms are probably top in the nation. Dr. Knowles and I, very experienced surgeons. And then, you know, when you meet staff members like Lakin and Moraine and some of our other staff members, you're just going to say, wow, their staff's really friendly. They seem like they care about their jobs. They care about the people they're taking care of. You put all those things together, and that's made us fairly popular with people.
One thing that I always do like to tell patients too is that when we're thinking cataract surgery, and we've talked about, you know, how accurate the cataract surgery is and how much better we can get your vision, you're also a LASIK surgeon, and you're able to perform PRK as well. So a lot of patients don't know that if they have their cataract surgery and they have it somewhere else, there's no other option. Once that lens is set, they're in glasses for life.
Yeah, you know, that's a big advantage of being a LASIK surgeon. You know, an implant lens gets you close, but let's say we do it and it's just not quite to our liking. It's a little bit off. Well, for us, we don't have to go back in and take that lens out. We can do laser vision correction, tune up right over top. We don't charge anything extra to do that. And, you know, the implant gets you close, the laser can get you closer. So we can fine tune, we can tweak things. And that's a big advantage for our practice to be able to do that as we fine tune things. Now, our formulas and nomograms per accurate, we don't have to do it very often. But if we do, it's not too hard for us to be able to do that. So yeah, that's a big advantage of being a LASIK surgeon too, is you can tweak things, you can fine tune things.
And then I'm going to go back to the questions because it looks like a few have popped up. We talked about glaucoma. There's a question from Diane that says, how long and how many people have used the upgraded lenses on? So I'm thinking,
you know, like, are these brand new? You know, that's a really, really good question. The first of these kind of bifocal implants came out about 22 years ago. So they're not brand new. But initially, kind of like the cell phones, kept getting better and better and better. Well, the lenses we're using now are 5th generation lenses, and they're pretty darn good. They have really tweaked things. Where we've seen big improvements, less night glare, less problems at nighttime with glare around lights. You get that with any bifocal implant you have. It's less now with the generations that we have, and just improved accuracy in correcting astigmatism. So these 5th generation lenses are really good. And I think we're kind of like plateauing off. It's like the last time I got a new cell phone, I can text people, it has really good camera, and I can call people pretty much like the one that I had before. It was just $300 more expensive than the one I had before. So I think that the implants are leveling off. I think the 5th generation set of implants is really very good. But yeah, we've been doing it 22 years. They're not a brand new technology. They're fairly mature technology now.
Okay, I'm going to go down a couple more here. Hans would like to talk about PVDs. So he says, I have PVDs in both eyes with early cataracts. Can you speak about vitrectomy followed by cataract surgery?
Yeah, the back of your eye is like a jello ball, and it's called the vitreous. And as we age, it dehydrates a little bit, it contracts, and then a lot of times it'll pull loose. And a lot of us will experience that at some point in our life. And when you get that, sometimes you get floaters. And most people have one of these. It's an annoying little spot in your vision. I have one over here in my left eye if I look in an overcast sky. And a few floaters are okay. But what you worry about is called a retinal detachment. And so let's go over that real quickly too. If you suddenly lose your vision from the side, tens or hundreds of floaters, or you just can't see out an eye, that could be a retinal detachment. Some people will see flashes of light preceding that, and that's when the vitreous is pulling on it. Now, if you've had a vitrectomy, your cataract surgery has to be done slightly different. We've got lots of experience doing that. If you've just had a PVD, that's a posterior vitreous detachment, that's actually kind of a good thing. If it's already pulled loose and you didn't get a tear, it's probably a good sign, right? So if you've had an atraumatic, a kind and gentle vitreous detachment or separation, that's probably a good thing.
That's something I didn't know. I've never heard before. So you learned something new.
I know.
All right, back to these. Let's see here. Let's see here. So there's one, and I don't want to butcher the word, but Carla says, I have a right eye with histoplasmosis in the central vision. Dr. Basinger said I had cataracts worse in that eye. Can you get the surgery in the bad eye and improve the peripheral vision as it was before the cataract? She said my good eye has the lesser cataract.
Yeah, that's a good question. And let's expand that a little bit bigger. Okay. So histoplasmosis, it's a fungus infection. It turns out 80% of people in the Ohio River Valley where we live have had this at some point. And for whatever reason, it tends to settle in the eye and you can get scars. Now, some people, they can get a scar right in the middle part of their vision. And that's real bad because they lose the vision. They can't see fine letters. Now, as the cataract grows, the vision will dim, it'll get worse, and you'll still need cataract surgery. But if you've got a big scar left over from histoplasmosis, but let's broaden that. Let's say the scar's from mac generation, or you got hit in the eye, or got a piece of metal in your eye, you got a scar from something. Well, that's still going to limit your vision. So it's called a guarded prognosis. When the cataract's bad enough, we'll still take it out. If you've got two eyes, we'll probably take it out on the bad eye first. We usually like to do worst first, and then we'll see what we get and then come back and do the good eye. So we can't fix the scar with cataract surgery. You might still have that, but you still might need cataract surgery to see your best.
Okay. Looks like we might be getting through some here. And current wait time to get on the surgery schedule. I can answer that one.
Yeah, I'll let you, because I'm going to tell them the wrong answer and Lake's going to say, no, no, no.
So typically the way that works is we are about, at the moment, we are about a month out on exams. And then from your exam, you're looking at about a month till your first surgery, and then another month till your second surgery. So it's a good time to try to get in before your insurance at the end of the year or HSAs run out. So it's a good time to start looking. It might be summertime, but it is a good time to start looking to get on the schedule.
Yeah, and then what Lakin alluded to, every doctor's office, because we all have high deductibles in today's world, is uber crazy busy between mid-October and the end of December. Every doctor's office is just packed and everybody wants to get in because they've already met their deductible. So that's a tough time to get in. So now is actually a pretty good time to come in.
We get a lot of calls starting somewhere in December where patients are like, I need to get in before the end of the year to get both eyes done. I've already hit my deductible. But usually in November, we're already scheduling for January. So it's a good time to look at it now.
Yep.
I'm going to go back to these really quick. And we might not be able to hit them all.
Yeah. The majority as we can. By the way, if we don't get to your question tonight, when you come in for your exam, it's very nice that we've looked at you. We can direct it. Oh, well, this is your eyes. We can measure you. So when you come in for your exam, we'll go over things with you and say, hey, yeah, this is what you've got.
Bonnie Moore, she wrote in that she says if she's had cataract surgery in one eye somewhere else and lost vision, can that be corrected?
Bonnie, that's the good reason to come in and see us. The answer is until we look at you and measure and figure out what happened there, we don't know. We do see that sometimes where people will lose some vision, and sometimes we're able to fix some of it, maybe not all, but some of it. And we certainly do second opinions or consults for that reason. So yeah, that would definitely be, whether it's us or some other really good practice, get in and see somebody and say, hey, is there something to be done? Can we remedy this? Can we fix this?
And then I'm going to go to another one. We have a patient that, or I'm sorry, an attendee that would like some maybe some clarification on the clouding after a new lens that has been put into the eye. So clouding, is it possible to have clouding afterwards? I know we discussed it, but maybe she came in just a little late.
Let's go over that. So you put the implant lens in, and it depends a little on your age and your health and things, but eventually the capsule, and it actually holds your implant in place, it clouds over, and it clouds over behind that. And when that clouding gets bad enough, then you're not seeing as well. So we take a laser and we clean it off with that laser. You don't have to go back in the eye. It doesn't require anything other than laser surgery. It's a relatively safe procedure. It just needs to be done once in your entire life. So we can clean that clouding off. So it has nicknames. Sometimes it'll be called a secondary cataract, but that's kind of a misnomer, right? It's not really the cataract, right? Capsule haze is a probably better word for it. And then, yeah, we can clean that off.
And here's another one. So we have a lot of patients that have a problem with this. Can surgery affect the dry eye, or?
Yeah, boy, dryness is really common as we get a little bit older. And if you're old enough to have gotten cataracts, you probably have some dryness. And we treat that a lot. I'll tell you one thing that's good to just start now, even before you get your cataract surgery, is to take by mouth orally flaxseed oil or fish oil. Turns out it's good. Yeah, there you go. Thank you. Good prop towards me, Lincoln. Yeah, flaxseed oil or fish oil, right? There you go. It's good for LASIK patients, good for cataract patients, right? And then use some non-preserved artificial tears, just like Lincoln is holding up there. She's really proud that worked out that way. So that'll help with the dryness. And then sometimes you get some crusting on your lashes, especially using those tears, and you can scrub those lashes and get that cleaned off. Those three things: lid scrubs, non-preserved tears, take your flaxseed oil. That helps a long ways. Now, after cataract surgery, most people notice their eyes are drier than it was to begin with for at least 3 months. And some people had dry eyes to begin with, and that can be a problem. Especially if you're working and you're on the computer, and we're all on our cell phones more now than we ever had before. Your eyes tend to dry when you're reading. So we have this thing we call the 20-20 rule. When you're reading and you're doing near work, every 20 minutes, I want you looking at least 20 feet away for at least 20 seconds and blink a little bit, maybe put some tears in. So 20 minutes, 20 feet away, 20 seconds, blink, put some tears in. It's amazing how much better that near work task is by just taking some breaks sometimes. But yeah, dryness is very common.
Very common. All right, I am going to run back to these questions, but I do think we've hit most of them. There is a couple questions specifically about certain insurance companies. That's something that we would be able to help more with in the office.
Yeah. And
if you specifically call your insurance company.
Correct. You can call your insurance company. Our website has a list of some of the insurance companies we know we're not on. I'll re-answer that. It broke up for a second. I'll re-answer that when we're back again. There we go. Hey, I'm going to re-answer that insurance question, which is a really good question. We try and be on every insurance we can. Obviously, on Medicare and Anthem, which is Blue Cross Blue Shield, and Aetna, and Moeller, and Humana, and Medical Mutual, and most of the common ones. But boy, there's 1,000 insurance companies that we work with. We do know there's certain that we aren't on, even though we've tried to be on them, and we try to list those on our website. So if you go to our website. But mainly you need to call your insurance and say, is this office on our provider panel, right? So.
And I'm just going to interject on that one too. It is important that you find out that our surgery center is also a provider for you. So we are Stahl Vision with doctors Brian Stahl and James Knowles. And then our surgery center is the eye laser surgery center. So you want to check to make sure both of those. It doesn't happen very often. Usually if you're covered at one, you're covered at the other, but there is one insurance I know specifically that you do need to check them. I don't know what the name of it is, but you need to check to make sure that we are on both sides for coverage.
And obviously if you come in, we'll be able to tell you that too.
All right, Dr. Stahl, I think we've hit pretty much everything that we have here.
Awesome.
Well, that was a lot.
I know it's good. And then I'm glad it worked. Until right then. So what's the weather like in Ohio today? Is it warming up?
Hey, it's actually 60 degrees here today.
Oh, goodness, thank goodness. When I left, it was snow flaring and it was like, oh my gosh, I'm tired of that. Well, it's 85 and sunny here in Jamaica, but I'm in the operating room almost all day long, so I'm not appreciating as much, but I'm hoping to get a little bit of sunshine and stuff. So, hey, I'll just put a plug in.
That's not a problem at all. Just so everybody knows, our office is actually closed tomorrow. We are having a team building exercise and some meetings tomorrow. So we won't be in attendance at the office. So Monday we are open from 8 to 5 if you are looking to make an appointment. The phone number that you want to call is 937-427-2020. So we actually won't be here tomorrow and we get to go enjoy the nice weather too.
Oh, that's awesome. They can go online too, right? For LASIK patients, they can schedule online, but not for cataract patients. But they can go online and find out information and find out next stuff too.
So they can't actually make an appointment for a cataract evaluation online because our schedule, we are kind of specific about how we put patients in for that. But they can request a consultation, and Denise calls every patient every time. And she's super nice. You'll like her a lot. She talks a ton, and she will definitely get you scheduled around your schedule, answer any questions that you might have. Absolutely.
Yeah, well, hey, we want to thank everybody who attended our seminar. Appreciate that. We do tend to record it and put it back up in a few days. So if you had friends that wanted to find out and didn't, they're going to be able to go to the website and they can watch it after the fact, which is really kind of nice. And look forward to seeing some of you in our office and hopefully help you see a little better too. And Lakin, thanks for setting us all up. Awesome job.
We worked really hard on it, but we got it together. We sure did.
We did. We're learning, right?
And then for the patients, or I'm sorry, the attendees also, if it takes a couple days for this to get put up or sent out to you via email, you can also check out our YouTube channel. The seminar that we did a couple months ago in October, maybe. That one is available for viewing right now with you, Dr. Knowles, and one of the cataract coordinators, Jessica.
Yeah, and that was a very good one too.
There's lots of information there, so you can watch some videos and things too.
All right. Well, thank you, Lakin. You have a great night.
Yeah, you too. Bye, everyone.